Hey study buddy, this is your local 4th year med student Eli Chen, and welcome to Pre-Rounds, where we'll talk through a case, review some high-yield topics for exams, and hopefully become a little less confused together. This is the Step 2 version of the case, where the information is geared towards that exam in particular. Check out the Step 1 version of this case if you're prepping for that instead. And lastly, I'm not a real doctor yet, so all the info and sources are taken from the real doctors and their guidelines listed in the description. And a quick disclosure, all of this information is for the purpose of education, and none of this should be taken as medical advice. So let's get started with our case today. We've got a 36-year-old man with 1 week of flank pain. Did he get run over by a 100-pound St. Bernard chasing a squirrel? Or maybe wake up on the wrong side of the bed? I don't know. Let's find out. So let's get an initial set of vitals. His temperature is 98.9 degrees Fahrenheit or 37 degrees Celsius. His heart rate is 70. His blood pressure is 128/84. His respiratory rate is 16. His SpO2 is 96% on room air. So let's find out a little bit more about the history. The pain started 1 week ago when he was trying to pee, and it's been on and off since then. Now it's gotten a little bit worse, and that's why he came in. He's been peeing more frequently, but still able to make it to the bathroom in time. Tylenol doesn't really help the pain, and the pain feels like a sharp stabbing pain on his flank and back that radiates to his lower belly and groin. When it's bad, it's about an 8 out of 10, and when it's off, it's about a 2 out of 10. He doesn't have any fevers or chills. He has some nausea but no vomiting. He has some blood in his urine but no discharge, and he's not really feeling any burning with urination. His last sexual activity was with women 8 months ago, and he uses protection consistently. He also has some occasional diarrhea and abdominal cramping, but none recently. For review of systems, he doesn't have any weight loss or fever or chills. He has some nausea and some difficulty peeing and some blood seen in his pee. So real quick, our differential diagnosis at the top of the list definitely includes kidney stones. This matches up with his colicky flank pain, the blood in his urine. He also doesn't have any systemic symptoms, which is a good sign, and these would include fever, chills, and unstable vitals. Other emergent diagnoses we can consider are AAA or abdominal aortic aneurysm. This would be more epigastric and back pain with palpable pulsating masses, leading into a rupture or dissection. He could also have pyelonephritis, but this is unlikely because he doesn't have any fevers or chills and his vitals are pretty stable. With his groin pain, I could be thinking about testicular torsion because he's young, but we can examine that more in the physical exam. Non-emergently, we're also thinking about UTI with his blood with urination and mild burning with urination. We could also be thinking about urethritis, but his most recent sexual activity was pretty distant and he doesn't have any discharge. So with that, let's finish up with the rest of his history. He has a medical history of Crohn's disease and no surgeries. For social history, he doesn't smoke, he drinks socially, and he doesn't do any recreational drugs. His occupation is a firefighter, and he says he might not be doing such a great job about drinking water recently. And his medication is infliximab for his Crohn's. On physical exam, he's alert and well-appearing. His heart is regular rate and rhythm. His lungs are clear to auscultation bilaterally. His abdomen is soft, non-distended, non-tender. He has normal bowel sounds and no CVA tenderness. On genital urinary exam, he has a normal appearing scrotum and no masses, and he's alert and oriented ×4. Because his vitals are pretty stable and his physical exam was pretty reassuring, there's not too much to do in the stabilization aspect. One thing that we could do is control for pain at the moment. For pain management for kidney stones, we're looking at some kind of NSAID, ketorolac 15 mg via IV, or ibuprofen 600 mg PO every 6 hours or as needed. We can also do morphine if it's really bad, and if you saw season 5, episode 17 of Parks and Rec, where Ben gets a kidney stone stuck in his ureter while preparing for his speech to accept the key to his hometown, he gets high on morphine for his pain, and the doctor says it's good stuff. And I believe it. And if he was having any nausea, we could do ondansetron or metoclopramide. For labs, I would get the basics, CBC, CMP, a calcium because there's certain kidney stones that could precipitate with high calcium. Also, because of his Crohn's, I'd want to get a little bit more electrolytes, so phosphate and magnesium as well, and I'd want to take a look at his urinalysis. So when our labs come back, the CBC and CMP are all within normal limits. His calcium is 8.0, which is on the low side, but that makes sense with his Crohn's, and that makes us reassured that he doesn't have hyperparathyroidism or hypercalcemia causing kidney stones. His phosphate and magnesium are also a little bit on the low side, but that is also due to his Crohn's. His UA shows dark yellow but clear urine. His pH is 6.5. Glucose is negative. He has trace protein, no bacteria, no leukocyte esterase, nitrate negative, 1 plus blood, and a specific gravity of 1.020 or 1020, which is more concentrated than normal, which is about 1010. So imaging for a kidney stone, we want to do a non-contrast CT abdomen. And why non-contrast? Well, CT is like a circular X-ray machine, and anything calcified lights up bright white, like bone in contrast, and certain kidney stones, like calcium phosphate and calcium oxalate. The contrast in the ureters would light up the whole urinary tract, and then you just can't see any of the kidney stones if they were present. It's like if a car was approaching you at night from the opposite side of the road with their high beams on, you can't see a thing. So when you use the non-contrast CT, you're more able to localize and measure the stones. So I read for this case, we have a left kidney that's enlarged, edematous, and some mild hydronephrosis. The kidney stone itself measures about 8 millimeters, let's say, at the junction of the renal pelvis and the proximal ureter. So, do we need to consult urology for this? I would say no, because he doesn't have any renal insufficiency on his labs. The stone is less than 10 millimeters, so we're fairly certain we can use medications to expel the stone. He doesn't have any fever or chills or any indication that he has pyelonephritis. He is also not pregnant, and he's also not a child. So our final assessment would be a 36-year-old male with a past medical history of Crohn's disease, presenting with 1 week of intermittent flank pain secondary to nephrolithiasis, or kidney stones. So our final plan is he probably doesn't need to stay in the hospital to wait for the stone to be expelled from his body. We can discharge him home for that. And there's a couple different types of kidney stones, and our management slightly depends on what it is. Kidney stone risk factors include diabetes, hypertension, obesity, and, in his case, inflammatory bowel diseases. His Crohn's led to a fatty acid malabsorption, which then sequesters the calcium to the fatty acid in his bowels. And this allows oxalate to be reabsorbed at a higher rate and causes calcium oxalate stones to precipitate in his urine. Uric acid stones, on the other hand, from gout or tumor lysis syndrome, could be treated with allopurinol or potassium citrate to alkalize the urine. Ammonium magnesium phosphate stones are treated by treating the infection first, usually from Proteus mirabilis with ciprofloxacin or ceftriaxone, depending on how bad it is and if he has pyelo. Cystine stones in kids could be treated with potassium citrate as well. So for our patient in particular, we want to make sure that his electrolytes are not too out of whack. Often in Crohn's disease, magnesium, calcium, and citrate can be low, so we can supplement that with magnesium citrate and calcium citrate supplements. In addition to correcting his electrolyte abnormalities, the citrate decreases risk of kidney stones as well. And for his diet, we want to limit sodium and oxalate intake because those can precipitate kidney stones, and we can also increase citrate with fruits and veggies. For recurrent calcium stones, we can consider potassium citrate and thiazide diuretics. Thiazide diuretics increase calcium reabsorption in the distal convoluted tubule. For hydration, we'd want a lot more water, so our goal would be 2.5 liters a day. And we also want him to follow up with urology for a 24-hour urine specimen. This is so they can do some more analysis on what kind of stone he formed and possibly mitigate some risk factors. To help the stone be expelled, because it was fairly large, it was 8 millimeters, we can use alpha blockers, including tamsulosin, 0.4 milligrams every night for 4 to 6 weeks or until the stone is expelled. Ultimately, urology is also going to give him a strainer to catch the stones. And for his chronic problems, he's going to continue infliximab for his Crohn's. And ultimately, for this patient, we chose a medical management of kidney stones. But when do we use surgical management? So generally, stones on the smaller side, less than 5 millimeters, can be treated with just pain medications via NSAIDs. For medium-sized stones between 5 and 10 millimeters, we can also add tamsulosin, which is an alpha-1 blocker. And for large kidney stones more than 10 millimeters, we would consider urology consult and surgical management. So for surgical management, there's different options there as well. If the total stone burden is less than 20 millimeters, we can do shockwave lithotripsy or ureteroscopic stone retrieval. Shockwave lithotripsy would be using sound waves from the outside of the body to break up the stone into smaller pieces, and that allows them to pass down the ureter easier. Ureteroscopic stone retrieval takes a camera and goes up into the ureter to try to retrieve the stone via a clamp or a basket. And if the stone is more than 20 millimeters, we can do a percutaneous nephrolithotomy, which makes an incision into the skin and retrieves the stone directly from the kidney. So the last section of the episode is curiosities and conundrums, and I was digging around the surgical side of things for this episode's rabbit hole. I feel like urologic surgeries are like playing a first-person cave explorer video game. The controller has like a joystick that allows you to bend the flexible scope to explore the renal calyxes, find the stone, and either pull it out with a basket, a clamp, or break it up with a laser or ultrasound first. And they're like professional spelunkers cleaning up your mini stalagmites and stalactites. It's also really satisfying getting a big chunk of stone out. So for retrograde intrarenal surgery to remove a kidney stone, essentially the camera is taken all the way up from the urethra to the bladder, up the ureter into the stone, and it's usually around the renal pelvis. It's a long way up, but this method doesn't make any new incisions and it generally has pretty good recovery time and fewer complications compared to the percutaneous nephrolithotomy that goes from your flank straight to your kidney. Well, one of the problems of the surgery is that there could be residual fragments or leftover pebbles stuck in the lower calyx. And sometimes the anatomy of the ureter and the renal pelvis makes an angle too sharp that the camera can bend that way to get it. Well, this 2024 paper is a prospective study tackling that particular issue. The surgery is traditionally done in the lithotomy position, where the patient is lying on their back and their feet are up in the air. And the researchers tried a Trendelenburg position, where they tilted the patient head down a little bit and 20 degrees to the right. If you haven't heard of Trendelenburg, imagine you're at a dentist and they're like, okay, we're gonna lay you down now to start cleaning your teeth. And you're like, okay, and the chair tilts back and you feel like you're clinging onto the chair to avoid sliding down like one of Sweeney Todd's victims in the chair at the barber shop. And then they ask, is this okay? And you don't want to make a fuss, and then you say it's great. But then you feel the blood rush to your head for the next hour. That's Trendelenburg. The idea is that the tilt towards the head will let the stones fall to the upper calyx instead, and then when the patient becomes upright after the procedure, the residual stones would fall and pass down the rest of the system. After 3 months, 92% of the patients in the tilted position were stone-free, compared to 72% of the patients who had traditional lithotomy positioning. I guess asking the patients to do a handstand for a couple hours to do the same thing isn't too reasonable, but I'm all for working with gravity, and sometimes the solutions are simple. So let's recap some of our teaching points. We talked about kidney stone risk factors, workup, and management that depends on the type of the stone. We talked about why this patient can be discharged, and if he had exhibited signs of pyelonephritis or fever chills or severe obstruction and acute renal failure, he would be a consideration for inpatient treatment instead. We also talked about how stone composition can change medications, for instance allopurinol for lots of uric acid, thiazide for recurrent calcium stones, and potassium citrate for uric acid and cysteine stones to alkalize the urine. We also talked about how management depends on the stone size. If it's less than 10 millimeters, we usually observe for distal stones, and more than 5 millimeters, we offer tamsulosin. And if it's more than 10 millimeters, we're generally looking at some type of surgical management. So that wraps up the case for now. Feel free to check out our other cases on the podcast in the meantime. Drop a comment to let us know how we're doing, and the next time you pass by your friend who's always just a tad bit too stressed, tell them that this too shall pass. It might pass like an 8 millimeter kidney stone stuck in the proximal ureter, but it'll pass. Alright, see you in the next one.